move on to the next session, my friend and colleague, Dr. Alfadel Alshaibani, is going to be talking about T-cell lymphomas, the promising trials and approaches. He's the T-cell guy at King Faisal Specialist Hospital, as well as the head of virtual healthcare. Dr. Fadel, thank you for being here.
Thank you for having me. So it's quite challenging to give a talk about T-cells after diffuse large B-cell lymphoma advances and Hodgkin lymphoma advances. But I will try to make it as interesting as possible. There are certainly some advances that we're making in T-cell lymphoma world, probably not as impressive as diffuse large B-cell lymphoma, Hodgkin lymphoma, but we're in the right track. So let's start with T-cell lymphoma. So when it comes to T-cell lymphoma subtypes, basically the subtyping of T-cell lymphoma is very different from B-cell lymphomas. In B-cell lymphomas, we characterize lymphomas based on germinal center, whether it's prior to germinal center, within germinal center, or after germinal center. In T-cell lymphoma world is a very different, very complex, basically subtyping. And this is why it's very difficult to have individualized therapies, and this is why some of the trial designs was not to the standard of, let's say, B-cell lymphoma. So this is basically gives you sort of a roadmap of what T-cell lymphoma subtypes is. You can have systemic T-cell lymphomas, many subtypes. There are cutaneous T-cell lymphomas, many subtypes, and you have basically the ALL part. If we dive deeper into each subtypes, the second most common is angioimmunoblastic. There is natural killer T-cell lymphomas and adult T-cell leukemia lymphoma, which we don't see here very often. And if the patient or the T-cell lymphoma doesn't fit any of these subtypes, they will all put it under peripheral T-cell lymphoma NS. And because of this, you can see variety when it comes to the response rate, and this is what I will discuss in a second. So making the challenging in T-cell lymphoma world is quite challenging. For example, anaplastic large cell lymphomas, if it's involving the skin, it can be very difficult for pathologists to differentiate it from, let's say, for example, mycosis fungoides. So having the clinical part of the equation is very essential in order to achieve an accurate diagnosis. So what about the frontline therapy? So SHOP has been the standard of care for so many years. In lymphoma wards, in diffuse large B-cell lymphoma is an R-SHOP, in T-cell lymphoma is SHOP therapy. What do we expect with SHOP therapy? This is a peripheral T-cell lymphoma and angioimmunoblastic T-cell lymphomas, the 5-year survival around 30. Around a third of patients will survive 5 years, the rest will die with SHOP therapies. There is an interesting subtypes which ALK positive anaplastic large cell lymphoma, they do better in general because they present early. However, I would caution that those patients with a high IPI score, if they are ALK positive, their prognosis is poor, similar to other T-cell lymphomas. So the first question that comes up, okay, SHOP therapy is producing around 30% overall response rate, 5 years overall response rate. Can we improve on that by giving more chemotherapy, by giving more intensive chemotherapy? This trial looked into that and basically was compared CHOP versus VIP reinforced ABVD, sort of intensive therapy in order to see whether the right approach is going intensive to achieve a higher response rate, and it was a negative study. And of course, patients with generally with anaplastic large cell lymphoma, they do much better than patients who don't have, who are not anaplastic large cell lymphomas. So, is there any way to improve on SHOP therapies? This has been already looked at. This is a meta-analysis of 7 trials that looked into addition of etoposide to SHOP therapies, and it showed benefit. It shows improvement in event-free survival in patients less than 60. It did not show it in patients above than 60, and this is basically the baseline of the recommendations. If the patient is CD30 negative, you add etoposide to SHOP therapy in order to improve the outcome. This is another trial that looked specifically into anaplastic large cell lymphoma patients, ALK positive, and it showed that the addition of etoposide to SHOP therapy improves the outcome. What about adding targeted therapies here? Many different targeted therapies has been tried. I will discuss some of them, but in majority, unfortunately, this wasn't translated into an outcome, and I will discuss why in a second. Brentuximab has been used initially in a second-line setting in a CD30 positive T-cell lymphomas, and it showed responses, CR rate of around 30%, and this was basically the baseline of Echelon trial, which basically included upfront patients with T-cell lymphomas who had an expression of a CD30 above 10%. Patients were randomized to either receive brentuximab SHEP therapy versus SHOP therapies. And as you can see here, basically the two groups were very well balanced when it comes to the age of the patients, the IPS score, the stage of the patients. And of course, brentuximab SHEP therapy, as you all know, achieved improvement in progression-free survival over SHOP therapy, and this translated into an improvement on overall survival in patients with, who received the brentuximab therapy in the front line. Who did benefit out of all T-cell lymphomas? Majority of the benefit was seen in anaplastic large cell lymphoma, and this makes sense because anaplastic large cell lymphomas, if you compare it to other T-cell lymphomas, if they are CD30 positive, you see sort of a patchy positivity, where in anaplastic large cell lymphoma is sort of a unified CD30 positivity, and this is why majority of patients were actually anaplastic large cell lymphoma, because they mandated more than 10% of patients to, patients to have more than 10% CD30 positivity to be enrolled in the trial. So most of the benefit, the progression-free survival was seen in anaplastic large cell lymphoma, and overall survival was seen specifically in ALK positive. Other subtypes, there may be benefit, but the number of patients was small, so it wasn't powered enough to detect the difference. What about the adverse effect? Nephropathies and neuropathies. Neuropathies and neutropenia is a well-known side effect of brentuximab therapy. Then comes the question, okay, so the Echelon trial put basically one of the eligibility criteria was CD30 positivity, more than 10%. Can we use it in a patients with a CD30 less than 10%? And the answer is probably yes. This is a phase 2 trial on brentuximab therapies in peripheral T-cell lymphoma, and you see responses throughout. You see responses with a low CD30 count, and you see responses with a high CD30 percentage. Part of this is probably immune histochemistry is not the correct way to evaluate the CD30 positivities, and there is variation depending on the biopsy. You can see a patient with a peripheral T-cell lymphoma who CD30 is 2-3%. When you repeat it 3 or 4 months later, you will see the percentage is higher. A similar story happened in cutaneous T-cell lymphomas. Progression-free survival was seen regardless of the CD30 expression. Of course, higher than 5% usually associated with a better outcome. So here we know that brentuximab improves therapy, etoposide improves therapy. What if we combine both of them? And this trial looked into that, the phase 2 trial of 48 patients, including CD30 peripheral T-cell lymphoma, and the eligibility for this was more than 1% CD30 expression. So we're not, in this trial, they did not use the famous more than 10% CD30 expression, and the outcome was impressive here. Overall response rate of around 91%, CR rate of around 80%. However, the follow-up was short, so a longer follow-up for this trial is needed to ensure whether this is actually transformed the care. This brings us to the question, after the frontline therapy, what is the optimum consolidation therapies? This is a retrospective from the Swedish lymphoma group. They looked into patients who underwent autologous stem cell transplant for T-cell lymphomas compared to patients who did not. In general, outcomes, 5 years survival. If the patient did not get an upfront autologous stem cell transplant, you're talking about 20%. If the patient get it, around 30%. Nordic trial is another trial that looked into the value of autologous stem cell transplant. And again, this was a phase 2 trial, and the outcome, again, you're looking at around 50% overall response rate and overall survival if the auto transplant was incorporated in the frontline setting. And of course, here, if you can see here, patients who achieved a response, a PIT-4 response, Duval score 3, 2, 1. After 4 cycles of T-cell lymphomas, they have a much improved outcome for patients who still has a disease at PIT-4. So PIT-4 is probably the right way to see which direction your patient is going to follow. What about the value of autologous stem cell transplant in brentuximab era? This is an extension of a trial, of echelon trial, the exploratory analysis that looked into patients who received autologous stem cell transplant who were enrolled initially in the brentuximab chip therapy versus patients who did not. And there is a positive outcome coming out of this. So autologous stem cell transplant is probably has a value in brentuximab era. Is this all what we can do in T-cell lymphomas? Of course not. Now we learned from diffuse large B-cell lymphomas and Hodgkin lymphomas, we probably need to go molecular, we need to go into targeted therapies. So let's dive deeper a little bit into T-cell lymphoma, molecular and pathogenesis. We have now an improved understanding over the last 10 years of the T-cell lymphomas pathogenesis. For example, angioimmunoblastic T-cell lymphoma, which is a subtype of T follicular helper lymphomas, usually they do have an epigenetic dysregulation, TET2, DNMT3, IDH2 dysregulations. There is apparent as well TCR signaling common, as well as other signaling pathway, JAK-STAT pathway and PI3K kinase pathway, and we'll see the effect of these, basically these alterations on the outcome of patients with T-cell lymphomas. So one of the things is looking whether adding epigenetic therapies to SHOP backbone will improve the outcome. If we dive deep here, we look into sort of the cellular, the oncological pathways and molecular changes in different types of T-cell lymphomas, but I will highlight here the angioimmunoblastic TET and DNMT3A. This is very remarkable when it comes to the outcome, and we'll see why. So this is a retrospective trial that looked into patients with T follicular helper cells and patients who T-cell lymphomas but not a T follicular helper cells who received romidopsin either as a single agent or in combination. As you can see here, if the patient has T follicular helper morphology, then the outcome, the overall response rate is around 56%, and the CR rate of around 30%. This is much better than a non-T follicular helper lymphomas. If we look into patients who responded, majority of those who responded had a DNMT3 mutations and TET2 mutations. This tells us probably the correct way is looking at the mutation at the start point of your therapy for patients with T-cell lymphomas. This is an old trial, raw SHOP trial that looked into patients with naive peripheral T-cell lymphoma. They compare SHOP therapy to romidopsin SHOP therapies, and this is basically, you can see here, it's a very well balanced between the two treatment group. However, the outcome of this initial trial was negative. Adding romidopsin, which they did it with a full dose of romidopsin, and they noticed a lot of cytopenias, etc. in the romidopsin arm, did not improve the outcome. However, they did then a retrospective sort of or analysis of different groups. Patients who had a T follicular helper lymphoma did see a response with addition of romidopsin to SHOP therapy. This tells us probably this specific group of patients, they do have an improved outcome with addition of romidopsin. I have to say that this wasn't a pre-specified criteria prior to the analysis of this trial. So what other therapies that we can use in peripheral T-cell lymphomas? Hypomethylating agent, azacitidine has been used with addition of SHOP in a phase 2 trial, and you can see here there has been some CR rates in azacitidine group. This is the Oracle trial, which used relapsed refractory T follicular helper lymphomas, patients with randomized to either romidopsin or investigator choice, whether gemcitabine, bendamustine, or romidopsin. And basically, this trial, it did show that azacitidine has an effect, but it's probably just giving it as a single agent is not the correct move. We need to combine it with something else. And this is what basically Jean Rouen from Cornell did it in the frontline setting. What she did is basically they would give azacitidine 5 days prior to CHOP therapy, and the idea is basically causing hypomethylation, and the hypomethylation exposing genes, making tumor cells more susceptible to chemotherapy, and then giving CHOP therapy. And with this, as you can see here, the CR rate was very impressive. The 2-year progression-free survival, 65%, overall survival, 70% of patients. If you look to the CR rate for all patients was around 65%. If you look to the T follicular helper lymphomas, it's approaching 80%. This is unheard of when it comes to T-cell lymphoma. This could be fine, and this is, you see it in diffuse large B-cell lymphoma. In T-cell lymphoma world, you're looking at around 50-60% max. So this was a land-breaking, basically, trial. There is now an ongoing phase 3 trial looking into azacitidine CHOP therapy versus CHOP therapy in a frontline setting. And I hope we hear from them in ASH. What about patients who did respond better within the T follicular helper lymphoma group? Is the mutation burden equal? Is TET2 equal to DNMT3A? No, it's not. So TET mutation correlates with a favorable progression-free survival. If you use azacitidine with CHOP therapy in frontline setting, DNMT3A mutations correlate with an adverse overall survival. Any other targeted therapies for peripheral T-cell lymphomas, EZH inhibitors, EZH2 expression has been shown in T-cell lymphomas, and this is very different from B-cell lymphomas. B-cell lymphomas usually it's a gain of function, and we have an indication in follicular lymphomas, for example. Here in T-cell lymphoma world is an overexpression, and this is a trial, this is the Valentina trial that looked into basically patients with peripheral T-cell lymphomas who progressed through 1 line of therapies, and they used valmetostat, which basically is an oral pill, and the outcome was an overall response rate, and this is basically the progression-free survival around 5 months, and median overall survival around 17 months. What about JAK-STAT pathway in peripheral T-cell lymphomas? So this is a trial from Sloan Kettering where they basically looked into relapsed refractory T-cell lymphomas, and they tried to stratify patients retrospectively who received JAK2 mutations into either they have an activating JAK2 mutations or just functional evidence of JAK2 mutations, or they don't have any, just a routine regular T-cell lymphomas. And those patients received ruxolitinib, and as you can see here, the response rate is higher if the patient has a JAK2 mutation. And this is basically, the response rate is consistent among different groups. Of course, peripheral T-cell lymphomas, they do have a higher response. Anaplastic large cell lymphoma, typically they do have a higher response than angioimmunoplastic. This is a second generation JAK2 mutation, and it's still in a non-randomized phase 2 trial in a relapsed refractory peripheral T-cell lymphoma. It's showing an effect with an overall response rate of 44% and a CR rate of close to 30%. So what does this leave us in T-cell lymphoma world? Again, the chemo backbone is probably going to be CHOP or SHOT for an extended period of time. The first thing that we need to do is basically to stratify patients according to the CD30 expression. Patients who have CD30 expression, they can benefit out of brentuximab. T follicular helper phenotypes, they do have a susceptibility to romidopsin, to azacitidine, as I just mentioned. JAK-STAT activations, they may respond to ruxolitinib if this is proven and PI3 kinase pathway as well activities. So if the patient is CD30 positive, brentuximab therapy is basically the standard of care, especially if this is anaplastic large cell lymphomas. Autologous stem cell transplant should be considered in chemosensitive patients. T follicular helper, if the patient has a T follicular helper cells, hopefully in the future we will see addition of azacitidine to CHOP therapy. This is still trial in progress, but this is where the future is heading to. JAK-STAT pathway, if this is a JAK-STAT pathway inhibitor, again, this is a trial JAK inhibitor in addition to SHOP therapy. Probably this is what will happen in the future of T-cell lymphoma. By this I conclude, and thank you.